Injuring your back can be incredibly frustrating and very scary if it's never happened to you before. The most common concern I hear from patients with new sudden onset back pain is worrying that they have blown a disc, or some variant of that. Are my discs injured? Are my discs degenerated? Yeah, okay, they probably are degenerated, but that likely has nothing to do with it. Go watch my other video. People rightfully worry about the integrity of their discs because disc herniations are moderately serious conditions that can take many months to get better. However, the good news is that as conditions become more and more serious, they also become more and more rare. In this video, we'll be talking about the textbook common signs for suspected disc injuries so that you can be more confident in whether or not you have a disc problem, or instead one of the very common, less serious sources of back pain. Disclaimer, which is always mandatory anytime I'm tossing out health facts. Conditions can vary wildly between presentation in individual patients. I'll be referring to the textbook and most common signs and symptoms of disc herniations, as well as using some generalizations. If you are experiencing low back pain, go get it checked out by a licensed healthcare provider and use this video as a talking point, but please do not rely solely on it for self-diagnosing yourself. Alright, let's get into it. As always, we're going to have to start with the anatomy. Our spine is composed of many vertebrae, which are the bones, that are stacked on top of each other, separated by spinal discs, which we shorthand down to just discs. The joints that hold these vertebrae together are the facet joints, which are located on the back elements of our spine. Each vertebrae has 4 facet joints on them, 2 above and 2 below. As well, located at the bottom of our spine is our sacrum. The sacrum attaches to our quote-unquote hip bones, which are known as the ilium, and this joining aspect is referred to as the SI joint, or the sacroiliac joint. Got all that? Awesome. Now, a classic example of a disc herniation occurs when the inner material of a disc, known as the nucleus pulposus, shoots out and to the side of the annulus fibrosus, which is the layer outside of it. Because of the direction of this offshoot, very often the very close by spinal nerves will become impinged upon. This resulting impingement of the nerve roots can result in a phenomenon known as radiculopathy, which roughly translates into shooting electrical pain down whatever the associated limb is. This is the case for sciatica, which describes a radiculopathy down along the sciatic nerve distribution. The sciatic nerve is the largest nerve in our body and goes down the back of our leg. It's one of the commonly impinged upon nerves with lumbar disc herniations. If a disc in your cervical structures or your neck is affected, you obviously won't be getting sciatica, but you could be getting radiation down either of the affected limbs, which would be your arms. These radiculopathies may be very intensive pain, and when not explicitly painful, may result in feelings of numbness or tingling instead. Okay, that all sounds pretty serious and scary, but I should remind you guys that the prevalence of disc herniations is only 1% of the population, or 5 in every 1,000 people. You are much more likely to simply strain a back muscle, which also sucks, but isn't as bad. However, in the case that you are the rarer exception, identifying this radiculopathy is the most important thing in diagnosing a suspected disc herniation, and this is done with a proper physical examination following an appropriate history. Let's get into that. Every musculoskeletal injury is caused by either movements that the body is not braced for through either improper form or insufficient unconscious proprioception, or trauma. Disc herniations may occur due to either of those mechanisms, but the most commonly associated mechanism for disc herniations would be improper lifting form, specifically trying to pick something heavy up off the ground. People who successfully herniate their lumbar discs usually do so because they're picking up a very heavy load with improper form, a rounded back, and fully extended knees. This form puts a very large strain on our lumbar discs, and all that pressure is directed at pushing backwards and to the side, which coincidentally is where the herniation then is pushed to. Or not coincidentally, actually, that kind of makes perfect sense. Bonus points if this lifting motion is also coupled with rotational movements. However, just as likely as a disc herniation is in this position, it's also even more likely that you would have just strained your QL muscle, which is one of our primary low back erector muscles helping us to stand up straight. This is why a history alone isn't sufficient. We need to get into the physical examination. People with disc injuries will very likely have pain in either their back or their neck. However, so will people with simple muscle strains or ligament sprains. So again, it's important to really look for that radiculopathy or the characteristic pain down the associated limb. Let's start with a range of motion exam. The most important movements to check here for our low back would be lumbar flexion, or bending forward, and lumbar extension, bending backward. True disc herniations will be aggravated by forward flexion. Not only will the pain be in the back, but you will also recreate that radiculopathy going down one of the legs. If your ability to bend forward is limited, check one for the possibility of a disc injury. However, if bending forward does not provoke any discomfort and instead bending backward is the thing that does it, you're more likely to have actually irritated one of your facet joints that we talked about earlier. This is because when we bend backward or lumbar extend, these facet joints are further pushed into each other, and if they're pissed off, they're not really going to like that very much. The same principles apply for a range of motion examination of our neck. Forward flexion would likely recreate some degree of arm pain. However, if you're extending backwards and you get that pain, again, probably a facet joint. In addition to this range of motion screening, one of the most tried and true orthopedic tests for lumbar disc herniations is the straight leg raise, which we shorten to SLR. If you are screening for this at home, first off, be careful. Second off, you'll need a friend. This test is performed by having the patient lay face up flat on their back, and then the practitioner will very slowly and very carefully, again, that's very slow and very careful, lift their leg straight up off the table, supporting at the ankle. It's important to ensure that the leg is kept straight. Pretty self-explanatory for the name. Continue lifting this leg up until there is either no movement, as in too stiff, or pain, as in radiculopathy down the leg or pain in the back. For a disc herniation, once again, we are looking for that shooting pain down the leg. It is common in the case of no disc herniation but a muscle spasm to have pain limited to only the back. To be thorough, practitioners will complete this on both sides, including the side that is unaffected. Note that the straight leg raise is only applicable to lumbar disc herniations. If we have a suspected neck disc herniation, a straight arm raise isn't a thing. Instead, there are 3 unique tests that are relied on to check the different cervical levels. We refer to these as the upper limb tension tests, and they're a little bit too complicated to just explain over YouTube. Disc herniations, while one of the more serious back conditions, are fortunately rather simple to treat. A combination of manual therapy, activity modification, and a specific exercise protocol known as the Mackenzie protocol, which involves building up to a cobra movement, can all be very effective in helping you to manage your lumbar disc herniations, and they can even be more effective when they're used in combination. The good news is that a near complete restoration of function can be expected, and that 90% of patients see a full resolution of symptoms within a 3-month time period. However, if after this 3-month period, conservative management with a licensed healthcare provider still hasn't seen good results with the patient, it might be time to consider surgery. But emphasis on that being rare, and it's always important to try a course of conservative care before you decide to do any kind of surgery. In summary, spinal discs are an often immediate cause of concern for patients with new sudden onset back pain. However, they are quite rare compared to other more common sources. If you're concerned about a new onset of pain, go see a licensed healthcare provider. They can help to put your concerns to ease. Disc injuries are most commonly suspected through physical examination and historical findings. They can then be confirmed through medical imaging following those. It's not necessary to get the medical imaging to begin treatment for suspected herniations, but it can be nice to have that certainty. And finally, 90% of the individuals who do unfortunately get a disc herniation see full resolution of symptoms within a 3-month period. This is with the guidance, of course, with a licensed healthcare provider. Thank you so much for watching, guys. As always, if you have a spare 3 seconds, please subscribe down below. It helps me to invest. You can click here for the previous video, and you can click here for the next one. As always, have yourselves fantastic days.